morning. Last time we spoke about a lot of the operational changes that were happening in terms of how we were approaching, the operating rooms and anticipating the surge. And I think at this point in time, it's a very critical period for us because we are starting to see stabilization of our numbers and hopefully a sense that we have peaked in terms of the clinical demand, so that we have the opportunity now to think about how are we going to start to pivot and get on the other side of this pandemic, and what is that going to look like. So that we have a couple of topics today, and I just want to explain how I think they're going to be potentially linked. Our department has very early on, since the very beginning of this pandemic, taken a pretty aggressive approach to thinking about scholarship and discovery, about how we should approach the pandemic, whether it is introducing the MENT scale that we that Dr. Prashant introduced. Has gotten a lot of attention from the American College of Surgeons nationally and in the press about thinking about how to ethically prioritize. We have some publications about informed consent, about how to reorganize residencies, and all sorts of really interesting statements that have come out of the department and concepts and frameworks that have come out of the department that are now being used by departments of surgery and organizations all over the country. The American Hospital Association, the AORN have adopted our MENTS philosophy, et cetera. While this has been going on, there's also an explosion of research at the University of Chicago for therapies, and you saw the premature press release about the remdesivir trial that's going on here, and there's a number of other clinical trials that are going on. And these are aimed obviously at treatment of the disease and thinking about how do we evolve a therapy and maybe develop towards vaccines and so forth. But I thought it was important to highlight some of the work that is being not just assisted or developed in this form, but really launched and led by this department. In particular, wanted to highlight Lucia Madariaga, who is one of our newest faculty members in the section of thoracic surgery, who's an expert in lung transplantation. And she'll describe how she's created and launched the convalescent serum program. And Dr. Alverdy will then also update us on some of the other research goings on. And then we'll hear from Ross Milner, will talk to us about how we're going to start to restore and start to gradually increase the capacity for time-sensitive surgery and how we're thinking about recovery there. Dr. Agrawal will talk about how we're thinking about this in the ambulatory space. And then we want to leave plenty of time for questions. At the end, are we still planning on doing that video? For folks who are interested in about video visits, we'll be able to stay on the call towards the end. We have a short video that will help. But again, I want to point out that what recovery means is not a return to normal, because we don't yet know what normal looks like post-pandemic and how long the COVID patients will be with us and the impact that they have on hospital operations. But more importantly, the critical flaws that the COVID pandemic has exposed and highlighted in our health system have been striking to many of us and have caused a lot of internal discussions in the department. Dr. Zackerson and Dr. Williams and a number of our residents are standing up an advocacy group to try to imagine how, from a Department of Surgery standpoint, we can think about what this pandemic means regarding social determinants of health and possible ways that we can impact that in our community. And I just want to remind you that I think at 3 o'clock today, the Dean is hosting a town hall about COVID and its impact on the South Side. on related themes. So I think we have to always keep attention on, we don't know what the new normal is going to be, and think about what opportunities this gives us to change the rules and change the approaches to how we think about providing care to the underserved. So I'm going to shut up now. And John, who is going first? Is it you or Dr. Madariaga going first? Okay, so I'll turn it over to John. Let's keep the initial discussion short so we have plenty of time for questions. Thanks, everybody. You got to unmute. You always got to tell the old people on these video calls, they have to remember to unmute.
What did you say? Okay. All right, let me just share my screen here, and I will get things going. Okay. So I just have a few slides to show, and again, thank you, Dr. Matthews, for the opportunity to talk. And I just want to say that, you know, as Jeff mentioned, no crisis should ever go to waste. And this department, between our residents, students, and faculty, have not wasted any time producing a degree of insightful and practical scholarship that is really sort of a very, very nice introduction to how we can work together to actually inform how to practice and understand this problem in the context of practicing surgery. Annals of Surgery, as many of you may know, is our sort of premier journal, and we have no less than 4 very highly cited already manuscripts there. The first one is Unknown Unknowns by Dr. Ava Ferguson Bryant, Dr. Milner, Rogan, Angelos, and Matthew. Surgical Consent, as Dr. Matthew mentioned, during the COVID pandemic. It was very informative. Nimble Together by Dr. Darren Bryan and Benjamin Schneider, Milner, Matthews, and Rogan on the training program, providing insight there. This was a very interesting article by Dr. Taraga and Hirotra on Are We Harming Cancer Patients by Delaying Their Cancer Surgery During the COVID Pandemic, with original data in there. And then finally, a really important paper by Dr. Zackerson, Matthews, Angelos, and others on what our role is as surgeons and the ethics and equity in this. Dr. Portugal from OHS published a very important paper on the safety of performing a tracheostomy in COVID-19 patients, and imagine just how high risk that procedure is. Dr. Vigneswaran addressed the issue of whether we should perform laparoscopy. And then Dr. Zhang wrote a beautiful opinion piece, perspective piece in the Journal of Surgical Research on working in the time of COVID as an Asian American. And then Dr. Milner, Donington, Matthews, and others have written on the ethical issues appropriate to continue surgical trials during the COVID crisis. And let's not forget our Dr. Williams, Brian Williams, who was on CNN with Don Lemon here, talking about the disproportionate the affected African Americans, both at UCM and nationally in this crisis. And as Dr. Matthews mentioned, you know, the MENTS score it's really an index that developed out of our morning huddles that we have in the executive leadership. And this is just really an incredible piece of scholarship that has many authors, as you can see, that contributed. And as Dr. Matthews mentioned, this has been highlighted by a number of very important groups, including the American College of Surgeons, and its altimetric score. I had Dr. Prashant pull this. It's just remarkable. It's only been out like a week and a half, and already it has just an incredible amount of visibility nationally and internationally. And I only have a few slides, 3 slides here, talk briefly about the SARS virus itself and the antibody response, which I know a lot of people are interested in. Recall that RNA viruses basically hijack our cellular machinery where they replicate, and SARS is no different. This spike protein is the protein on the outer surface that binds to this ACE2 angiotensin converting enzyme receptor that internalizes the viron particle envelope where it can unfold and replicate. And this spike protein is the protein that is used to create the ELISA, the sandwich ELISA. It is used to measure the titer of antibodies against COVID. Now, why don't we have an antibody test so that we can know if we have protective immunity, if our patients have it? Well, a yes/no IgM antibody test, even measuring titers only, tells you you've been exposed, but it does not tell you that you have protective immunity, and that's a problem. In many patients recovered from COVID-19, their IgG antibodies disappear 1 month later. We do not yet know at what antibody titer patients are protected against COVID-19. However, we do know the antibody titer at which in vitro binding to ACE is inhibited and viral replication within cells is inhibited. These are the in vitro immunoneutralization assays. But keep in mind that studies demonstrate that recovered patients, even with antibodies against COVID, can still be shedding active COVID. And we're not exactly sure, is this active replicating? Is it transmissible? But it's not a guarantee that that either you're immune or that you're not infectious. So there is a number of FDA-approved tests that are coming online, but they're only approved and indicated that you've been exposed. They're not approved for clinical decision-making yet. So remember, this disease is only 4 months old, and as a result, we're learning a lot, and we're continuing to learn. Now, I just want to show you this for you to understand briefly that when we make good antibodies, we obviously coat the spike protein and the viron. The virus cannot get into the cells, respiratory cells or GI cells, and that's good. But there are also non-neutralizing antibodies that actually facilitate entry of the virus into macrophages, which then activates the entire pro-inflammatory cascade, which is not good. And we have literally a world-class investigator in this field. He's published in Science, Nature, Cell, the most incredible body of work looking at the antibody response specifically to influenza A and other coronaviruses. So we're very fortunate to have that. So this is my last slide, and I will let Dr. Madariaga talk. But think about 3 risk scenarios. The scenario at the beginning, in the postoperative day, -5 to maybe -90, where your patients had neoadjuvant RT, use of biologic, exposure to antibiotics, which Dr. Wilson has actually written can impair the antibody response to the virus. Then what we do in surgery, which we know is immunosuppressive, and then the risks of recovery from surgery, where patients can get infections, they can bleed. And we are in a position now where the COVID status cannot be determined to be constant. It would have to, it's not tractable. And so remember that a nasopharyngeal swab still has a 30% false negative rate. So while we're trying to develop an assay to say we are a safe hospital and our patients are safe and our surgical teams are safe, we're not there yet, but we have all the tools and the people and the reagents here to test that hypothesis and actually create and develop the information to use. And I will stop there.
Okay, Dr. Madariaga, assistant professor of thoracic surgery. She's been in the department for like 4 months or something.
I started in February.
February, so even less than that. And has, in absolutely record time, put together a high impact, high visibility trial out of the Department of Surgery, enlisting all the collaborators. It's really extraordinary work.
So I'm going to do a brief overview about the plasma trial that we're conducting at University of Chicago. And so just as a bit of background, this is taken from Dr. Casadevall's review paper earlier this year about convalescent plasma therapy. Basically on the left, you have a patient who is sick with COVID-19 in red, and then he recovers or she recovers. At that point, they are convalescent. And the whole point of convalescent plasma therapy is to transfer what one may think are virus neutralizing antibodies from the convalescent person to a person who is either sick or in hopes of prophylaxing against the virus. And Dr. Alverdy mentioned how there's many pitfalls in in all of this therapy, but historically it has worked in the case of prevention with measles, and then in cases of treatment with influenza, MERS, and SARS. Of note, in developing countries, for example, you don't need to fractionate out the serum or the plasma. This therapy can be given as whole blood therapy, and in doing so, transfer the virus neutralizing antibodies. So here at University of Chicago, what we are doing is assessing the feasibility of delivering anti-SARS-CoV-2 convalescent antibody plasma to hospitalized patients. They're greater than 18 years old with severe or life-threatening COVID-19 disease, less than 21 days from illness onset. And you can see here that the definitions of severe and life-threatening are quite broad, and they're taken from the FDA guidelines. An important part of designing this study was that we didn't want to burden a strained hospital system while COVID-19 pandemic was going on, and we wanted to keep everyone safe. So we tried to design this study in a way that minimally impacted hospital function. This is a picture of the first convalescent plasma that was harvested last week from a donor. And I think what was really good about our donor setup was basically it's a patient-facing operation for our study. We're bringing people into the hospital and showing them how we work. And they're the first interaction that many have had in a hospital. As you can see, this is a young gentleman who was among our first donors. And it's really all about customer service and making sure that their experience is streamlined and happy. So we are taking plasma donors who are age 18 or older, confirmed COVID positive tests, who are at least 28 days from symptom resolution. I mentioned here our dedicated hotline, email, and web address, because basically all of our donor recruitment is done over the phone and online to minimize interaction and keep social distancing. So as a testament to all the hard work that our donor team has been doing, since the start of our study, which was on April 10th to yesterday, we have had 483 donors interested in our study approach us. And we've gone through all of them and kind of sorted out in what category they are. 127 donors had met all the entry criteria of having confirmed COVID-19 test and greater than 28-day symptom resolution. We've enrolled 106 study participants so far. As of yesterday, 15 have come forward to donate blood. There are 7 people coming in today to donate blood. And 89 of our people are scheduled to donate within the next 3 weeks. So you can see it's quite high volume study. On Monday, we did our first plasma transfusion, and you can see that it's hanging here in this patient who was sick. So far, we have 3 patients enrolled and transfused since Monday. One was a 57-year-old male healthcare worker, some comorbidities. He had received tocilizumab, and he rapidly deteriorated, was intubated and prone, and he got plasma. Another gentleman, 61-year-old man, police officer, no comorbidities. He was desaturating on room air. He had inflammatory markers and had some lung findings, and he qualified for our study, so he got plasma. And another one is a 51-year-old female healthcare worker, some comorbidities, who actually failed tocilizumab and remdesivir, the antiviral therapies, currently on VV ECMO, and she also got plasma. So that's ongoing. I just want to bring up this slide because there's a lot of people that help make this happen. And this is a quote from Dr. Donington, who at the early stages of this trial and getting it off the ground told me that we will not let you fail. And that is actually the most true statement I've heard in a long time. So basically on the top left, I want to highlight my thoracic surgery team and my general surgery colleagues. They've been instrumental in getting all the donors in a really timely and efficient and lovely process where every single donor that we've interacted with in the donor center has loved University of Chicago and thinks we're the best, better than American Red Cross. On the bottom left is Patrick Wilson. In one of his Zoom conversations, we have many Zoom conversations together to discuss the science of what we're doing. And I think it's really important to highlight that our trial is basically collecting data that we feed to Dr. Wilson's lab every single day from all points, from the donors to the recipients. And he's using that data so that we can then feed back and try to improve how we take care of patients. Then we have a lot of partners from across the institution, the blood bank. Some of the ladies at the blood bank are really excited about our project. And then we have the IRB, infectious disease and medicine. Of course, our leadership, my husband. Infrastructure, very important. We set up everything online and through RedCap, so it's very easy for people to access us. And then clinical research support. So that's all for me.
Great. Thank you so much. That's really important work, and you can see how this is really going to help drive us some novel therapies and lays the track for some of the serologic testing that's coming on. So why don't we pivot now to recovery and start with Ross and followed by Nishant to update us on how the department is sort of thinking about recovery and how we're going to sort of inform the rest of the organization on the approach.
Great, thanks. Good morning, everybody. Jeff, it's usually, I'm always following you. It's not usually fun to follow you, but it's actually even less fun to follow John and Lucia. That was amazing presentations. I'm just here to load the trucks, basically. You guys have really done some amazing work. So thank you so much for sharing that. Every time I have an opportunity to talk about the operating room environment and recovery and how we're planning, I always just want to stop and say thank you to everybody, from all of the attendings, the residents, our PAs, our APNs, our nurses. Everybody has been unbelievably thoughtful, unbelievably patient, and this is a trying time for all of us. And we have more than stepped up to the challenge, not just clinically, but as John and Lucia have shown, we've done it academically as well. And I think as a department, we can be very, very proud of everything that we have done. And I think, as Jeff said, through Vivek's publication with MENTS, we've really set the standard around the country now for how to handle medically necessary time-sensitive surgery. And really through the statements that you saw through that joint statement from the 4 societies, that we've done a great job in how we've managed this locally and to the best that we can, and have set a good example for the rest of the country and internationally. And I've had multiple friends from around the world reach out about Vivek's paper to have questions about how we've implemented that here and how it's impacted not just our triage during the pandemic, but how it's going to manage our recovery after the pandemic. So as you know, we've used the MENTS system to help us transition from the standard operating room schedule, which everybody was accustomed to before the pandemic, through Jeff's really just outstanding leadership and vision. We were very rapid in our decision to be conscientious with the hospital resources, with our staff, with ICU space, with bed space throughout the hospital, and really turn off the spigot to the nasty word that we don't like to say anymore, which is elective surgery, which is part of the recovery, which will come back into our vocabulary. We have, over the past little bit, been functioning at a total of 16 rooms between the CDOR and Comer. We are today going to increase that total complement to 20 rooms, which is outstanding, and is in the setting of knowing that our COVID positive patients have been stable on the 8th and 9th floor in the CCD, and we have the physical capacity now to release space on 3 Central that was previously dedicated for a COVID floor that has not needed to be utilized. But our ICU space still remains very tight and still restricted. So as we've opened up these additional rooms, we're able to focus on the low MENTS, low length of stay patients and try to still be very restrictive with ICU patients because there is not a lot of beds available for those patients. As the section chiefs know, and as many of the faculty know now, rooms have been reassigned. So you won't have to come to me for permission for every case anymore. But it doesn't look like the standard block schedule. And as Jeff said, recovery with the block schedule may never get back to the new normal block schedule. We'll have to see how things evolve. Right now, the blocks that have been allocated were based on the number of cases that sections or departments had in terms of displaced, delayed cases. And really, we've tried to get it so that people can get caught up as quickly as possible with the resources that we currently have. The DCAM plans are still in place. I'm going to talk about that a little bit more with recovery, but right now DCAM operating room is still not open. The COVID testing, as you heard from John and Lucia both, is not perfect. There is some false negatives that occur, but we've been using it much more now for preoperative testing, and that system has been working well. You can continue to contact me if you have any patient that is scheduled for a MENT surgical procedure that you would like preoperative COVID testing. I will continue to help arrange that. And if that burden of patients becomes too much for the team that's helping me, I'll have a new paradigm for you all. So what does recovery look like? Thankfully, we're starting to talk about it to the point that many of the phone calls that I'm on each day, which previously had been focused on disaster management, are now focused on recovery, which is exciting for all of us. The two major committees that I sit on right now with the recovery relate to the inpatient hospital and the census throughout the hospital. And then as quickly as we built the COVID spaces, trying to figure out the right cadence to take down the COVID spaces. I think, as Jeff said, we're probably going to have a number of COVID positive patients in the hospital for a while. And the second group is obviously the peri-op group and peri-procedural group. There's an ambulatory group as well, and Nishant is involved with that. May 4th, hopefully, will be a critical day for us. Depending on the decisions from the state and from the governor, we're hoping that on May 4th, we're able to open the DCAM operating room again to approximately 50% of capacity, which means 4 operating rooms running, because we have to have appropriate social distancing for the patients as well as potentially visitors. And the visitor policy is also being discussed as we increase the amount of MENT surgery and being able to have patients have family members potentially come with them. As I've mentioned, the block schedule is still in evolution, as is the block committee, and we're going to use this change in what's happened with the operating room to really allow us to evolve and to potentially do things differently in the future and really critically look at block. Our goal is by hopefully the end of May to have DCAM back to fully functional, and also to have the operating room close to fully functional and get as close back to 100% as we can by hopefully early June, mid-June, but that is really dependent on the rest of what the hospital looks like. But again, for me, I really just want to thank everybody for their patience, their interest, their constant feedback, and it's really been a tremendous group effort by everybody, including our anesthesia colleagues and our nursing colleagues. So thank you very much.
Okay, now Nishant Agrawal has been spearheading our thinking about the ambulatory clinics and how we are going to be outwardly facing towards patients who have had their surgeries delayed, postponed, and how we are going to start to take new patients in, how we are thinking about video health, et cetera. Go ahead, Nishant.
Thank you. Thanks, Jeff. So I also want to thank everyone on the Zoom conference for your sacrifices, for your perseverance, for your patience, and really trying to maintain our tripartite mission. It's been almost an impossible challenge, but as you see, we're rising above it. So I'm just a spokesperson for the Recovery Task Force for the Department of Surgery. We have an amazing team of administrators and faculty, and we bring in other people as needed. Our priorities are our patients. That's our foremost priority, and that includes both our established and new patients, and then our referring physicians, our resident and fellows, and then also marketing communication. You know, the financial bit of things we're not considering right now because we think if we can get these other priorities right, the financials will work themselves out. So, you know, as Jeff has said, we're in recovery phase, but this is a new normal, and telemedicine is not going to go away. And I would challenge all of you to be creative and think about ways to adopt telemedicine. Even if you think your subspecialty doesn't apply, you can figure out a way. You know, I'm a head and neck surgical oncologist, and you can say, like, how can you do telemedicine? You can. You can figure out a way that you actually will still do the right thing for the patients. So just be creative, and you can figure out a solution. So almost all of our patients, both established and new patients, should be scheduled for a video telehealth. I know there's some workflow issues, and at the end of this, I'll sort of take you through this. But really, we don't know when we're going to go back to normal, if we're ever going to get back to normal. But regardless, telemedicine is not going away. So when we identify medically necessary time-sensitive issues, then we can schedule patients for in-person visits. If patients have pending surgeries, I would really encourage you to contact them, set up a telehealth visit, provide an update, check their symptomology, and see how they're doing. And then all the canceled patients that are now being rescheduled, don't just say, oh yeah, we'll see when things get back to normal, I'll see them then. Schedule them for a telehealth visit. Otherwise, they will get dropped off. They want to maintain that physician-patient relationship, and it is imperative, and it is our mission to provide the best care, which includes during this time in the pandemic. So in terms of what our options are, the institution has adopted Zoom. I know there's mixed feelings about this, but they adopted it because we have great Zoom backgrounds. But I think it's much more than that. They went with this platform and use it. You can complain about it, but use it. I think there are multiple reasons. There is a lot of security behind it. You saw the emails from the security team yesterday. They're able to sort of fix security issues and work together on this. If there are issues with Zoom, you have other options. So Zoom is encouraged, everything else is discouraged. It doesn't mean that you can't do the other things if Zoom does not work. So you have access to things like FaceTime, Doximity, Doxime, WhatsApp. All of this is a temporary fix. It's about 6 to 8 weeks, and we're going to have an integrated system through Cisco into Epic. So that's in about 2 months. So this is all temporary, but even 2 months is a long time if your patients can't contact you. For our in-person visits that are identified through a telehealth visit, we've already set up a SOP, which has been rolled out through the Department of Surgery, where patients will be pre-screened by a call 24 hours prior to their visit for COVID and ILI symptoms. There's two sort of ways of thinking about it, whether you block your in-person visits together to preserve PPE, or you separate the in-person visits for social distancing. I think each section and each provider can figure that out. And there may be some opportunities from home health type related things. The staffing in the ambulatory, we've sort of titrated staff depending on where things are. And I think the practice managers, the nurse managers have been critical in this. The APPs can really help with these telehealth visits. The PSRs, their roles have completely changed, so don't get frustrated, be patient. They're also learning something new. They're checking in our patients. Some are checking all of them in together. That's not a sign that they're being lazy. That's probably actually the most efficient way of doing this. And this was brought up yesterday during our call. So checking all of the patients in together is probably the most efficient way of doing this. In terms of our facilities, so we encourage them to isolate the COVID clinics, and that is going to go to the Mitchell ED. There will be phone screening for in-person visits. We're going to be doing universal masking and exercising social distancing. And the testing has already been discussed, both the advantages and limitations, but both for patients and healthcare workers. We're working with a call center for template management. This is another major issue which we became aware of yesterday. So we're troubleshooting that. But essentially, I would encourage you to give the green light to the call center to use your existing templates and just schedule telehealth visits into that. By that default, your schedules would get full. And really, there would be very few exceptions that I can think of. The call center has sent my chart messages to patients, and we're exploring televox and email messages that we can send to patients. Radiology, so we've been in contact with radiology. They're also sort of doing the men's mentality, but it doesn't mean that you cannot get imaging. You can get imaging. It may be delayed, but if the patient has a medically necessary time-sensitive issue, the imaging will happen. IR, there's some workforce issues there, but they're also getting back to speed. We're working on extended hours or formalizing different blocks, and we're working through staffing and union considerations for that and coordinating ancillary services. We're also exploring satellites such as Ormond Park, South Loop, and River East. and also our English facilities, including Tinley Park. Tinley Park Ambulatory Surgery Center is a very important opportunity for us to do outpatient cases. So if you perform those types of cases, please consider getting privileges there. We are staying connected with our referring physicians through calls and texts. Please stay in touch with them. This is our lifeline. In terms of our residents and fellows, as a task force, we decided that the ambulatory clinic will be the primary responsibility of the clinical faculty and EPP, but there are mechanisms through Zoom for resident and fellows involvement. And then really we're trying to do a big marketing push. We're drafting communications both centered to patients and referring physicians, sending it out by different means, including social media, which say that we're open for business, but with telehealth as the primary point of contact. And it's safe, that we are going to exercise universal masking, screening, checking temperatures, social distancing, testing. And also the third thing is as a source of information. We are the source of information for our patients and referring physicians. Instead of them Googling some information, they would just come to the U Chicago web pages. So it's sort of a multi-pronged approach that we've taken. And some of this we've accomplished, some of this is work in progress. But thank you for everyone's engagement. Thank you.
Great. Thank you very much. So now we have a number of questions that have started to come in. Please use the Q&A function if you have one. We're not going to be able to do voice questions from participants, but we will take them written. So the first one, Ross, can you answer Kevin's question about the men's cases, cancer cases, and rethinking block times?
Yeah, for sure. Kevin, thanks for the question. I think I'm going to answer this in two parts. It'll be a little bit easier for me to address that way. The first part about the current paradigm of the quote unquote new block scheduling that we have right now. The ask from us as perioperative leaders was for each of the section chiefs or department chairs, depending on what the infrastructure is, such as ortho and OBGYN, is to keep a priority list of cases, which Doug and his administrative team have done that within the Department of Surgery, and have an order that we would want to accomplish in terms of getting the cases done. So this will still happen through the section chiefs in terms of the priority of the cases, but it won't require the approval of the leadership team unless there is a high MET score or the need for ICU. So these cases should still be looked at, and it should be prioritized based on the rest of the cases within each section. So I hope that answers your first part. The second part, in terms of the opportunity to link block times with robotic equipment, dedicated room for non-trauma, racks, et cetera, this is the opportunity we now have with the changes that we've seen as we reestablish what will be a block or non-block schedule to take all of this into account. And as we look at the block committee and as we restructure the block committee and potentially restructure the way the operating room looks, this will be our opportunity to potentially make some choices that are different than we've used in the past, and potentially have some opportunities for other services to have appropriate time in the operating room. But it will be dependent on how things evolve, but it is an issue that should definitely come to the block committee as we restructure that and restructure the operating room setup.
Yeah, let me make a comment about the block committee. There has been a block committee that's been led by Doug Dershel. I asked him to handle block schedule requests to try to make this a sort of broadly participative process over the last couple of years. But what the block committee over the last 3 years has devolved into is just a committee that meets regularly in order to say no to new block requests, because basically the entire block schedule has been, totally, booked out with very, very little room for flexibility, except when we've been able to bring on an additional room by construction. So there's been really very little wiggle room and very little ability for the block committee to do anything truly fundamental and creative. We now have the opportunity, crazily enough, through this disruption, to rethink everything. And there probably are lots more efficient ways to think about how we bring back scheduling predictability, how we bring back the priority cases first that are patients that have been waiting, and then how do we bring new patients in, and what does that look like? It may be a much more open system rather than a block system, but this is what we're going to recharge the block committee and reconstitute the block committee to try to think about strategically. So the suggestions that you made, Kevin, and that some of the other departments will have in individual sections, that's exactly the place where those things should be discussed and thought about. There was a question that John Fung had about DCAM reopening, ambulatory. And the thought is, and it'll depend very much on the issues that both Nishant and Ross raised regarding patient perception, et cetera. But our hope is that we're going to be able, in the earlier part of May, depending upon the governor's stay-at-home order, to get at least 4 rooms open in the DCAM ORs for true ambulatory type cases. Again, ambulatory cases can be medically necessary and time sensitive, just like anything else. So we'll certainly take a look at that. But we're hoping that within the month of May we'll be able to do that. Dr. Madariaga, there was a question that was asked about what were the entry criteria for what was the questionnaire for entry criteria for the trial?
Yes, for this specific trial, we're treating patients with severe or life-threatening COVID-19 disease. And then the other question was, how does that play into all the patients in the hospital and all the different kinds of trials we are offering at University of Chicago? And the answer is there's a dedicated COVID-19 treatment disease team that makes an algorithm for what patients qualify for which trial. And it's continuously updated. Actually, there was a meeting yesterday to see how plasma would fit in. And basically, there's on all the drug trials, there's lots of exclusion criteria. For example, people who have high creatinines or et cetera, and several of the drug trials do not allow concurrent plasma therapy. So basically we are considering all those factors. And at the end of the day, if the patient doesn't meet any of the trials, they can get plasma, and we don't exclude anyone.
Yeah, there was a question about Tinley and other sites. Doug Richardson and I are having weekly calls with Brian Synott and Titus Daniels from Ingalls. And one of the topics that we are addressing, and obviously some of the constraints on Tinley are the same as we face in DCAM in the face of the stay-at-home orders, but how can we think about leveraging that space and start to, again, take advantage of the disruption to work more like a system with them. I had a conversation yesterday afternoon with Dr. Flynn about the same point. And again, I think crisis spells opportunity for that. So that's certainly possible. Nishant, can you answer Dr. Skelly's other question, which is about patients who don't have access to computers or IT? I know that there have been conversations about this already. I worry in a new world of telehealth that this exacerbates existing disparities in access.
I agree. So I think not everyone will be able to access this technology. Then I think you can resort to just a telephone telehealth visit. But I would say that we don't know. I think a lot of people have smartphones, whether they're Android-based or Apple-based. So if Zoom doesn't work, there are other options. So you can call the patient and say, do you have any capability of video conferencing? And they can say yes. And if they do, you can exercise that. So if you are sort of flexible in your approach, you can make this work. If they say no, then there's no alternative. Then you get a telephone visit, and that's perfectly fine. But at least we've attempted to start the video conference, because I think seeing the patient is very important. Making that connection is critical. And there's other sort of downstream advantages of the video telehealth versus telephone, but it may not be possible for everyone.
I think that this is a topic that if it's not addressed on the Dean's Town Hall this afternoon, ought to be asked from the audience. Again, how do we get into the situation where we're disrupting, bringing in new technologies to care for patients in the post-pandemic world? How do we do that in a way that doesn't exacerbate the existing disparities there? And
And these disparities are being brought to the forefront through education, through elementary school, public schools. It's the same thing, that disadvantaged students may not have access to this technology. So I think it's a societal issue that we're going to have to confront.
Yeah, we're going to really have to figure out how to, it's, you know, as we've talked about in other settings on the ethics call and hopefully on our advocacy call on Friday, you know, these issues of how do we create a new normal, and as a Department of Surgery impact and try to get ahead of some of these disparities is important. Ross, there's a question from Dr. Balke about robotic cardiac surgery patients, but the broader issue is about testing the surgical team and OR personnel. Can you handle that?
Yeah, I'll try. So Sam, thanks for your question. This is still being evaluated, and the concept of who and when should be tested, I guess, is the best way for me to start it. So is it a daily test? Is it a weekly test? Is it only if people have symptoms? And it's not clear what the right paradigm is, but I think some of the issues that Nishant mentioned earlier in terms of our universal masking, you know, isolating the patients that are COVID positive, and we're still working on our recovery plan and our visitor policy as it relates to your exact question on what the right time frame for testing is. There will be some aspect of this, but it's not been fully defined what that's going to mean. But it wouldn't surprise me if we're somewhere in some sort of frequency of testing for healthcare workers. So if nothing else, even though it's inaccurate, as John showed very well, at least it gives people confidence that we're thinking about it and they know that there's some thought process going into it. And the universal masking help, and all the shields in front of our PSRs help, and everything that we can do to give the perception that it's as safe as possible.
Yeah, I think it's probably going to be the case that we as providers are going to get used to getting a nasal swab stuck up our nose on a weekly basis. I think that's probably in our future. So enjoy.
Chef, can I just make a comment to follow up on Piper's question? So I think the biggest injustice for us would be that we don't contact our patients by any means. So whether it's video or telephone, I think we have to try. I think the disparities become greater if these patients have no connection to us. So just let them know we're here, and you can triage some of these things, and you may have to have a lower threshold to have patients who don't have this technology to come in, but at least we have that connection.
Are there other questions from the participants? Oh, with the increase in certification. Yeah, great. This is a great question. Ross, you want to handle this question that came in about how do we keep patients out of the ED and some pathways that are being thought about for that? It's a great question.
So we've actually, I've had a lot of conversations with the residents, and I know hopefully a number of you are on here. The number of attendees is tremendous, so I assume there's a huge resident turnout as well. So there's been a lot of good discussion between the attendings and the residents in terms of some of these logistical issues which are different in this environment. And with Andrew and Drew and Darren, I had a very good conversation about the best way to try to handle this. This should go through the attending physician. If you get contacted and there is an issue with a patient at home, we are trying to avoid having the patients come to the emergency department if we can. If there's an issue that can be addressed by having the person admitted, the hydration, imaging, whatever needs to be done, that's appropriate. I will say in general though, the emergency department volumes have been much lower than anticipated, and they usually see over 200 patients a day, and they're only seeing about 170 patients per day right now. So there is capability and capacity in the emergency department if patients need to be seen, but we're trying to avoid that risk of exposure if possible. And if there's a question with the patient, just the attending will have that patient admitted directly, and the appropriate workup can be completed in a short time in the hospital.
Great. Are there other questions from the participants? Why don't we take this time to go to your video, Nishant? How do we do that? Is that it?
Jeff, it's not a video. I was just going to walk through a patient scenario through Epic.
Okay,
so this would probably be applicable for the attendings and the EPPs. And if anyone
maybe
else
the
wants,
anybody
maybe the
use it.
resident.
So this is yeah. So if you're interested in seeing how a video visit works and how the documentation works, Nishant will walk us through that now, sharing his screen. if this isn't relevant to you, you can drop off feel free to drop off the call. And hopefully you'll be able to attend the Dean's Town Hall this afternoon on Southside health during the pandemic. And then we'll see you at other conferences over the course of the rest of the week. Okay, go ahead, Nishant.
All right, so, you know, on a call yesterday, I think there was some issues about struggles with the approach with Epic and if everything wasn't done properly. So, you know, I've logged in remotely to UChat to get the applications, and I'm just logging into Epic, and I will. So now I've logged into Epic. So, you know, we worked pretty hard to change all of these visits, but even if the worst case scenarios, these visits are not video return, so you can see most of these have been converted, but I'm going to go to the 29th where I put in a test patient. So this is a regular visit. So there's been a breakthrough in the system. They weren't scheduled to a telehealth visit, a regular visit, but I'm going to do a telehealth visit. So I'm going to double click.
Nishant,
yeah.
I think we may not actually all be able to see the screen that you're looking at. We're still seeing your web-based UCHAPS form.
You have to adjust. Paige says that you have to adjust sharing to show Epic and not your browser.
But this happened.
Yep.
Can you guys see this clearly? Because it's like screwed up on my screen.
It's screwed up on our screen too.
How about now?
The option. Oh, that's it. There
That's
it is.
it? Okay.
Yeah.
So I just clicked on the patient. So again, there's been no check-in. Someone dropped the ball. It wasn't converted to a telehealth visit. No one checked it in, so the patient hasn't arrived. But I can simply just click to start the visit. And now I have everything I need to keep moving forward with this visit in any way I want. And I can write my note here. And I've created a smart set. So Nishant, telehealth. And so I can enter all this information. So I have telehealth visit, who my referring physician is, and then the disclaimer at the end, that the attestation that this is a virtual visit, this is the patient's identity confirmed and how many minutes I spent. And then the key thing for this is to use the express lane. So you just click on express lane. And here, this is the fastest way to do this encounter is you can enter the information by clicking on it. And you can mark, and then here I can do sort row. And then, so now I'm going through all my encounters. I've written my note. I'm going through all the medications of my patient, the problem list. And this is sort of where the billing is. So let's say I had an issue and my patient did not have access to telehealth, and this was a telephone visit. I can just see telephone visit, 5 minutes or 10 minutes, whatever it is. But if I did do a video telehealth visit and it's a return patient and I spend 15 minutes, I can just do this. So then you have to sign the express lane here. And in terms of your communications, if you have to communicate anything, this is sort of where we were before. And then if you have notes to the front desk or behind the scene desk, you can go up to wrap up, follow up. I can say follow up in 6 months. I can tell my front desk please schedule in person in 6 months. So, you know, if I wanted a video telehealth, I would say schedule a video telehealth, schedule a telephone telehealth, or schedule in person right now. And that's it. And then I can go to sign encounter, and then you can fill in the stuff. Sinusitis. Sorry, I forgot to click one thing here. So if you go to problem list, you can just click on this and that'll give you what you need. And then I didn't do all my stars in my note, but if I did all that, then it would let me sign the encounter. If this doesn't work and you want to create you want to send an invitation to the patient for a Zoom, then this is the UChicago Medicine Zoom. You sign in. And here you can say schedule a new meeting and save, and then invite attendees or copy this invitation. So you can copy this invitation and you can email this to your patient. So if, again, this is worst case scenario where something was dropped and there wasn't adequate planning in terms of the Zoom meeting, the Zoom telehealth, or they weren't properly checked in, none of this should prevent you from completing this visit. So any questions?
This is great. This is all very helpful. I don't see any additional questions. I would say that it's probably a universal wish that we get templated notes like you've created for yourself there across all the different sections. And so we'll have the section administrators and the section chiefs work to make sure that everybody's got such a perfect thing. There's a question here: how does dictation incorporate into the telehealth visits? Do we have any information about how dictation?
So I don't know actually the answer to that. I would say it's probably wouldn't be the most efficient workflow if you were dictating a telehealth visit though.
Dr. Baruti says it incorporates just fine.
Okay. Perfect.
So maybe you could work with Fuad and come up with an answer that we could send around to everybody about here's how you do that. We could just send it around to the providers.
Yeah, sure. We can send that out today.
And then we have a question, should we invite the patient to a video visit through MyChart? Is that how that works?
Yeah, so you can do it through MyChart. You can email them, you can text them. You know, I think this is all your comfort level. Like some people don't feel comfortable sharing their email or cell phones. You know, our emails are basically public now. Cell phones, I understand. But yeah, you can share this through MyChart. There are many different mechanisms.
I think this, the question really reflects the broader issue that we're all just getting familiar with this. And we have to, as providers, as faculty, our APPs, residents, we have to get good at this. And so the next couple of days and weeks, we've got to figure out how to troubleshoot. Our ability to be nimble and really efficient with telehealth and video visits is absolutely key to our ability to serve our existing patients, to bring in new patients, and to sort of enter this brave new world of telehealth. We've got to get good at this. If you're like me, you know, I hate this more than anything in the world. I just want to sit in front of a patient. I'm really old-fashioned at this, but we've got to really figure out how to do this and incorporate it. There's some, Lou Portugal saying, use the CSN number attached to the patient encounter for video visit as an identifier on MedScribe and use dictate. All right, we got to get that as an option into your response there. Yeah, Dr. Bendix is mentioning that we're trying to bring iPad technology into the hospital to try to use patients who don't have visitor access to be able to communicate, but we're also using that, and Dr. Bendix has a really great initiative to bring iPads into the violence recovery program visits. So we've got to figure out how to get that outside as well. I think Piper Skelly suggested the idea of creating outposts where people could go to, get a video visit. In other words, you can imagine you could have an ATM where you go up, you punch your number in, and now you got a video visit, and you can connect to your doctor. Maybe that technology can be part of a Southside initiative. Again, something that we're going to have to brainstorm around. I mean, there's going to be a huge amount of opportunity to innovate in this space. I can tell you that the telehealth companies are out there. You look at their stocks, like Teladoc is like going through the roof, buy now, because that company is going through the roof. They're going to be exploiting this marketplace. We got to figure out how to do this in a way that serves our patients and our community. Good. All right. We're just past 8 o'clock, and I know people have a lot of work to do. We will follow up on a lot of this, get some follow-up information out, and we'll move on from there. We'll see everybody hopefully on the call this afternoon, on the town hall, and these other activities. So thanks everybody for being with us, and enjoy your day.